To start off this evening, we have our editors. I am also trying to condense their very extensive CVs into a very small number of words. So Dr. Jaro Kotalik is a professor at the Northern Ontario School of Medicine and the founder of the Centre for Healthcare Ethics at Lakehead University. He has both a medical background in oncology as well as bioethics experience, including consulting and serving on committees such as the National Council for Ethics in Human Research. David Shannon is a lawyer practicing health law in Thunder Bay. We're going to see a Thunder Bay theme this evening, as well as a lecturer at both the graduate and undergraduate level. He has a Master of Law degree from the London School of Economics and holds many honors, including the Order of Ontario and the Order of Canada, for his work advancing the rights of disabled persons and other minority groups. So Jaro and David, I will turn things over for both of you to introduce your book and to tell us more about the genesis. And as the moderator, I'm going to have the challenge of making sure that we allow enough time for everyone else as well later in the program.
When creating the book like that, the issue was what should be the yardstick, how we should decide about what the program is doing. We didn't want to produce another book about whether euthanasia or assisted suicide are good or not good. We wanted to actually look at the concrete program we have in Canada called MAiD and see what this program has been doing from initiation to present state based on available information in public domain. This already restricted our inquiries because the amount of research done in this field is actually very limited, but we still thought it's a time to review and put together what we know. So as concerned the yardstick, we decided that actually the best thing is to look at the law itself. And the preamble to Bill C-14 is providing us with five objectives or commitments, I would say, which the law made to Canadians. So I will just refer to them and see what we can think about how these commitments are being followed or being abandoned. So commitment number one was that the people who have competency and capacity to be autonomous decision maker and who suffer from incurable illness and suffering which has not been relieved and want to obtain assisted dying should be allowed to do so. But the second commitment was that, in fact, that power given for individual decision-making has to be balanced against the interest of vulnerable segment of the population and against interests of society. In the initial law, this balance was defined as being assisted or created by limiting access to MAiD to people whose death is reasonably foreseeable. But as you may know, as in Bill C-7, a few years later, this condition was removed. There no longer needed to be a foreseeable death. It could be any long-term disability or chronic disease which would create eligibility. So that raises the question: how is the balance maintained now when this condition is out? So that's one of the issues which certainly we wanted to explore. The other commitment was too vulnerable, and it was defined as a need to assure that people who are vulnerable will not be induced to give up their life, and particularly in moments when they are in distress and when they are prone to make a decision under a situation of fear and so on. So if that concern about vulnerable is spelled out in the preamble, well, we had immediately when we look at that issue, we realize there are dozens of accounts in the media about people who were actually in that vulnerable group, and they were induced, in fact, or there were attempts to induce them to accept the MAiD. There is a big difference between induction, somebody to do something, and providing information. And this is also one of the chapters explained in the book. So we are concerned that that promise has not been well followed up. And so we devoted some time in the book to this issue. And the other one is, other promise was that there will be a robust safeguards for protection to avoid abuse and error. So, law admitted that could be errors in putting people to death, and that there has to be a safeguards for that. Well, again, there was a safeguards, many of them, there was a list of safeguards in the first edition of MAiD law, but a number of those safeguards were removed by Law C7. So, for example, 10 days waiting period between the application or approval and receiving MAiD has been removed. So technically now, MAiD could be provided to a person who applied in the morning, could be that in the evening. So we have issue is there's those other safeguards which are on the paper, but are they being followed? Some of them are hard to measure. They may be something which happens between physician and patient only, and nobody's witness to that. So we wanted to explore the issues of safeguards. And finally, the law in the preamble suggested that we have to affirm inherent and equal value of every human life. So again, we don't have great studies to look at these issues, but we have numerous publications in the media which saying us, no, this does not work. And we have advocates for these people with disabilities. They tell us that since MAiD was implemented, people with disabilities are looked much more as a potential candidates for MAiD, regardless what conditions they have, just because of their disability. So what the law was trying to prevent actually is happening. So these were the kind of yardsticks we were working with, and so these are the main concern already which we expressed in the book. But there are other issues which David will expand on.
Thank you, and Rebecca, thank you very much. This has been a pleasure. This project, a pleasure that now over 2 years ago is working with you, Jaro, beginning with a phone call to commence what turned into one of a monster of a COVID project, lockdown. Saying yes during lockdown could be a very interesting thing, eh? Thank Cardus, though, and thank everyone here tonight to join us. As you'll see from the table of contents, and as you peruse the book more deeply, there's 30 chapters. That's but well over 30 contributors, of course, lead authors, assistant authors, and people who have participated in the creation and contributed to the book, all of whom we're deeply thankful for. But more importantly, it was a breadth of knowledge, a breadth of, we would hope, knowledge translation in their work. We had clinicians, law professors, lawyers, bioethicists, all working, creating their own chapters, and we found many overarching themes arising, many that you've already heard from Jaro, in particular with respect to vulnerability. And as many of you are aware, the MAiD may be allowable or as of March of next year. So now it's just a a few months down the road, MAiD will be extended to persons suffering from mental illness, or if we use the words of the Ontario Mental Health Act, mental disorder. This does create a new concern for those who are vulnerable, and the questions are, where is the information come from as to when it is appropriate? Should it be appropriate? What are we doing with the information? Who is asking the questions? All important think tank questions. We have been finding that it's not currently, the information is not fully mature, fully evolved, and it would be appropriate to see that date of March be further extended. It was to be it was to become law a year ago, last March. That was extended for further study. It would make sense to now, 5 years on since the law has changed, to further mine the data, take a look at the question of such questions as what groups are there, at-risk groups that have a higher preponderance of MAiD? Are there trends that we should be alerted to, and come to understand, and also how is this monumental change? One small amendment to the criminal code has created a monumental social and health practice change. What has that meant for Canadian society? What has that meant for Canadian culture? And quite frankly, I think one of the overarching themes was we don't have all the answers we need yet. The information's only beginning to come in, and we need to go much further before going deeper into this question of social policy, health change. And a very interesting theme that arose also was the question of, is a small amendment to the criminal code the right place to create social and health practice or health policy change? As a lawyer, I have certain concerns about one being a penal code and then trying to apply it to social and health, society and health. We've also seen, in terms of safeguards, more robust safeguards or regulations. An evolution of the regulations would be most appropriate now, so that you can identify more credibly, why are people choosing? Is it for despair? Are they choosing MAiD because they fear being a burden to their family? They fear utilizing too many resources in the health care? Or is it also fear of suffering that they've not, due to a diagnosis, and they've not had time to adjust to disability? Inherent in we will hear that from Dr. Marini soon. And then furthermore, this inherent tension where we are today as a society, with a tension between the rights of autonomy or liberty rights versus the rights to equality or community-based rights. Where is that balance? Where are we turning toward? Because we didn't get a full answer from the Supreme Court yet, which was, in the Cardus decision, I would suggest was very focused on what's called Section 7 rights, or rights of autonomy, life, and liberty. And they stayed away from Section 15 or the question of equality rights. One of the principles in Bill C7 is that there shall be an adherence to the principles of the United Nations Convention of the Rights of Persons with Disability. And with that mind then, of a broad, holistic view of human rights, first, second, and third generation human rights would be appropriate. And it would seem many of the overarching themes are we need to go further and better. And if I might just end it, there's also been a lack of multidisciplinarity in many of the assessments. So it would be appropriate to have the further contributions of social workers, psychologists, psychiatrists, palliative specialists, and often these persons with very important contributions to be made provided during the process of assessment are often voices not heard. So multidisciplinarity would be very important as this now further moves from federal sphere to provincial sphere. And we expect that the provincial sphere to see more development in the area of administrative bodies, even administrative law. And that's it is certainly not matured either. So with that said,
I would like just 1 minute to add to the comment. I mentioned that in the preamble, first objective or promise was to provide access to assisted dying to people with autonomy and competence. Well, I should have said that goal has been certainly fulfilled. And so we have that 30% increase every year of number of people who receive MAiD. And we have in a world record of percentage of the people who receive MAiD in some of Canadian jurisdictions. And so it seems that the attention to that first goal and concern about provides that what was defined as a human right in Canada based on Constitution absorb all the energy of our healthcare system. And these other goals which I mentioned, which are important, some social and medical view has been ignored. So I think we hope to bring attention to that disbalance. The balance was disturbed and we don't have the balance now. So we want to bring attention to that situation.
And inherent in all of this, as we will tonight be discussing it at a rather blue sky and academic perspective, and the book has done that in all 30 chapters. We never lose, and I'm hoping no contributor lost within the intellectual discourse or the marketplace of ideas that this is a truly human and inherently human story. And we're mindful of those who chosen MAiD, the impact on their families, and how deeply personal this is, and for each individual and their place in the larger body of the human fabric, the human condition.
Absolutely. And I commend both of you for not only the monumental task of corralling so many clinicians and academics together to bring this book to fruition, but also for the scholarship it represents for the Canadian context, as well as what it will offer to international jurisdictions who are interested or considering these kinds of policy changes to look at what the Canadian experience is. And I really appreciated both of your chapters as well that look at issues of safeguards, monitoring, reporting, and some of the problems there within, and identifying some of those practical things that are falling short in how we're approaching this issue.
That's right.
So on that note, we're going to transition a little bit to have one of our speakers join us from the University of Texas. So we're going to ask David and Jaro to make room so that we can see him on the big screen. So while we're doing that, I will introduce you to Dr. Irmo Marini, who's a professor in the School of Rehabilitation at the University of Texas, Rio Grande Valley. He has a PhD in rehabilitation, as well as a master's degree in clinical psychology, the latter of which is from Lakehead University, hence my comment earlier about the Thunder Bay theme of this evening. Alongside numerous publications, he also has awards for his research in rehabilitation. His co-authored chapter in the book is titled The Psychosocial Aspects of Adapting to Traumatic Non-Life-Threatening Disability. I'd also like to recognize his co-author, Laura Villarreal, who's also part of our online audience. So hello, Laura. And I'll invite Irmo, once we get him up on the screen, to tell us more about the chapter that he produced and how this adaptation to disability is impacted by the introduction of MAiD. So welcome, Irmo.
Hello, everyone from South Texas. Laura and I are about 20 miles north of the Mexican border. So When I first came here, a sociologist welcomed all the faculty and said, "Welcome to Northern Mexico." And I didn't understand what he meant at the time, but I certainly do now. My wife and I have lived here since '96, and it's predominantly about 90% Hispanic. Thanks, Rebecca, for recognizing Laura, my co-author in this chapter. I'm going to, many people probably don't know this, but Dave and I were injured in the same year, 1981. Dave was a varsity athlete at the bottom of scrum playing rugby, and I got injured during a varsity hockey game, checked into the end boards. So I also have a quadriplegia, much like Dave's. With that said, I'm going to share my screen with the time we have, and we'll get right into it. I only have a few slides, and I know I have 5 minutes, but this is basically our topic. Is that good?
Yes, we can see it very clearly.
Okay, so I've spent my 30 some odd years as a researcher and publisher looking at this, and like any movement or to find out where we are today, it's really important to look at where we've been. And so persons with disabilities have always been seen as helpless, incapable, and really second-class citizens or less than others. Many of you in the audience and online have probably read about the eugenics movement in Canada that led to sterilization of people with disabilities, certainly started here in the US in 1907 in Indiana, and eventually morphed into extermination in Nazi Germany, with an estimated 300,000 German citizens with disabilities being euthanized. The current statistics are more charitable, but we still are seen as viewed as incapable and pitied, more so than anything else, subject to discrimination, poverty, oppression, and low employability. Civilian and physician views of persons with disabilities generally, unfortunately, haven't been great because of projection. Able-bodied people perceive those of us with disabilities as having a poor quality of life and a poor life satisfaction, when numerous studies of us basically show that we adapt to disability, and that most of us, not all of us, but we do report a higher quality of life than most able-bodied people perceive, as well as life satisfaction. But the perceptions persist not only in the media, but in movies, like the movie You Before Me, which, despite everything going for the young man, death is preferred and actually carried out. I hate to be a spoiler at the end of the movie. There exist over 40 theories, but most postulate that we go through stages of adjustment, similar to Kubler-Ross's stages of grief: shock and anxiety, bargaining, denial, mourning, internalized anger, retaliation, acceptance. The DSM-5 accepts about a year as a normal grieving period. And beyond that, it's called persistent complex bereavement disorder. But it's similar to stages of grief. So when you and I have lost someone very close to us, varying for all of us, stages of grief are very similar to stages of adapting to a disability. Other theorists indicate more intermittent contentment and sorrow. And then finally, other theorists, and I sort of believe and experience the stage theory as well as this last one, which is really more how we adapt to our disabilities, is really interdependent on how we view the world and how we perceive the world views us. In other words, society, and how we get treated. And so this, according to sociologists, is very important. And so the sociologists basically say societal attitudes, physical barriers, and community acceptance and resources that are available to us. Dave will be happy to tell you that Dave and I, coming from Thunder Bay, was one of the most advanced cities, if not the most advanced cities, not only in Canada, but North America, because of advocates with disabilities before us who went to every city council meeting and demanded services. So when Dave and I went to Thunder Bay after spending almost a year in Lyndhurst Hospital in Toronto being rehabilitated, we went to available integrated housing right away. We moved into apartments that were just down the hall from each other. So if the above critically intricate attitudes, services, and care are in place, most everyone that Dave and I have met throughout our life enjoy a good quality of life and good life satisfaction. Alternatively, if these things aren't in place for many people, both in Canada and the US, then this leads to lives of despair that eventually lead to deaths of despair. And if MAiD is so easily accessible for this population, then with not enough governmental support and other types of support, then it's sort of an easy decision. My last slide here talks about the intersectionality with disability, both having lived it personally for 42 years, like Dave, and as a researcher. The other thing I guess I didn't tell anybody, but I also have a private litigation practice where I work with personal injury lawyers on both sides of the aisle. And so I've assessed hundreds of people with disabilities across the country. I've gone into their homes, and some of them are living in really dismal situations. Others are a little more well off. But my overall take in all this, and talking to Dave the lawyer, is that MAiD in its current form just doesn't seem, and I think Jaro mentioned this, and I know others after me will mention this, there doesn't appear to be a big enough stopgap, and that a family and MD can sign off on this. And as Jaro mentioned, relatively easy. And so my ideal thinking on this is that you need a psychologist to sign off that the individual is not clinically depressed and can't first be treated successfully to come out of that state. So I believe that needs to be in place. I think with those of us with traumatic injuries like Dave and I, as opposed to, I'm really sorry I didn't count on that. Hold on here. For those of us with traumatic injuries, we need about at least a year, consistent with the DSM-5 to adapt to our situation. Because when we're first injured, and I'd be the first one to admit, with all the interviews I did in Toronto, I did want to die. I mean, I just hated being inside my body. And as time went on and I went through rehab, and I was in the physical therapy every day, getting stronger, and with occupational therapy, learning to live and do with what I had left, my mood and everything got better. So I think up front, the government or other private entities who have an interest in this have to do more to make sure that we don't endure lives of despair and pick that way out. Canada, the world has to acknowledge we ignore to various degrees the needs of people with disabilities. And if we choke off socially just means to thrive, we contribute to our early demise. That's all I have to say about that.
Thank you so much, Irmo.
Should I stop sharing?
Sure, yeah, come up on the big screen again. There we go.
Okay.
One theme that I saw throughout the entire section of the book focused on disability perspectives touches on a lot of what you were just saying in terms of the MAiD system is set up to provide assistance in death, but there's a lot of issues that are already existing in terms of providing assistance to live. And of course, something you also mentioned in your chapter and came up in other chapters in terms of some of the discrimination and ableism that people living with disabilities encounter in the medical system especially can also impact how they're going to be assessed for MAiD and how they're going to be provided with other care. And I realize that these are deep-rooted issues, but how do you think that we need to be addressing them in the context of the MAiD regime in Canada?
Again, there needs to be more stopgaps. Ideally, and this is ideally, here in the States, we have 11 states and/or districts that have assisted suicide. We need in most of these areas, we need at least 2 physicians to sign off, and preferably one being a psychiatrist, as well as a psychological evaluation. And certainly, as Jaro indicated, and I didn't know this till Jaro mentioned it, but you can't get up in the morning and say, hey, I feel like dying today, and then, as Jaro indicated, be dead by the end of the day. That's just unbelievable. So we have to wait a mandatory period of time and have all those other stopgaps in place to really see if we can help the person, either funding or what have you, to get out of these lives of despair. Because certainly those of us like Dave who have thrived, and the millions of other people who have sort of not succumbed to their disability but have thrived, it's the last thing on earth we'd ever consider.
So we're going to thank Irmo again. Thank you so much for sharing your perspectives with us. So without further ado, I'm going to introduce our 3 panelists. We have Dylan McGuinty Jr., Leonie Herx, and Sephora Tang. I'll give you, again, that very condensed bio, and I encourage you to find out more information about their credentials through our website or, as Ray was mentioning, through the power of Google. So Dylan McGuinty Jr. is a lawyer who works in the areas of consent, capacity, substitute decision-making, estate planning, and estate administration. He has a master's of philosophy as well as a Juris Doctor in law. His practice involves working with elderly and vulnerable persons living at home, in hospital settings, and in palliative, hospice, and long-term care. Dr. Leonie Herx is a specialist palliative care physician and professor and has worked in numerous leadership roles in this field. This has included, among many other contributions, co-founding the new Royal College subspecialty in palliative medicine. She has been an expert witness both in Canada and internationally on the topic of palliative care. And we at Cardus have benefited from her expertise through her role as one of our senior fellows for the health program. Dr. Sephora Tang is an assistant professor in the Department of Psychiatry at the University of Ottawa, as well as the program director of the Psychiatry Residency Training Program. She has been an expert witness before Parliament and an advocate for access to quality medical and mental health care for vulnerable and marginalized persons. So Dylan, I'll start with you and your chapter, which happens to be the first chapter in the book. Your chapter discusses the court's adoption of what you call radical autonomy and the implications of this on the common good. Can you tell us more about this concept and about your concerns about its impact in the context of MAiD?
Thank you, of course, and thank you all for being here. You could have been in, I'm sure, many different places tonight, but you decided to come to this event. And so I feel privileged to be here and share the stage. To answer your question, I'd like to start with the notion of a moral anthropology, right? So starting with big terms, but it's this notion that there can be an understanding of what it is to be human, right? That has implications for how we should behave, right? And it seems to me, anyway, in my journeys and readings and studies on the topic and my meetings with many different clients of different walks of life, that It seems to me that on the whole, in Canadian society and in big cities anyway, there's been a sort of throwing overboard of this idea that there is a moral anthropology that we can all roughly agree on, if not at the edges, then in the main. And when we throw out what we understand to be human nature, then I think what we're left with is what I would like to term radical autonomy. This idea that it comes down to the autonomous individual, understood as autonomous, sometimes not so autonomous when you start digging down beneath the surface. And my concern with that is you quickly find that when one radically autonomous individual, radical being here the notion that from the roots, radical from the roots, that we've overthrown the notion of what it is to be human that we can all agree on, right? When you overthrow that from the roots, people can make decisions, and often do, that are very harmful, and often in invisible ways, but very persistent ways, very consequential ways. So there's sort of this double notion with radical autonomy in my pieces, the throwing over of a notion of human nature, of a moral anthropology, and secondly, the trampling over the good of other people, right? Because when we understand what it is to be human, we can understand what it is that is the good or the common good.
And I'd like to ask Leonie if we can draw her into the conversation. The more I've been learning about palliative care, about its holistic approach to the human person, it doesn't accord with this radical autonomy, because it sees the human person as something much deeper and much bigger. And one concern that was raised continually when we were debating about bringing in MAiD in Canada was the idea that it's going to impact palliative care and impact the ability to provide care for people who are facing a life-threatening or life-limiting illness. And we were told, no, it's not going to be a problem. We're going to be able to expand and improve palliative care at the same time. There's not going to be an issue. But your chapter really provides a sobering counter picture to that. Can you tell us more about that?
Yes, thanks. That's a great question. And just to thank Cardus for hosting this event, and David and Jaro for the opportunity to contribute to this important body of work that I hope many people can learn from. So you're right, Rebecca. Actually, the Supreme Court in their Carter ruling talked about how there was no universal access to palliative care, and that's something that the International Association of Hospice and Palliative Care and the World Health Organization have strongly advocated that before any jurisdiction even considers legalizing euthanasia, they should make sure that there's universal access to palliative care, so that unmet suffering is not a reason that's driving requests for people to end their lives early. And the Supreme Court said, we recognize there's not universal access to palliative care, but we think that this can be leveraged, this legislation can be used as a leverage for palliative care to be advanced in Canada, and that will be now the task of the politicians. But the reality that we've seen in the past 7 years is that there has not been significant advancements in the access to palliative care. And in fact, it hasn't changed very much at all from the knowledge that we have in the past 6 to 7 years. But what we have seen is that these limited finite resources for palliative care are being diverted towards MAiD. And I give many examples in the chapter, but some of them include the utilization of hospice and palliative care unit beds for the sole purposes of providing euthanasia or MAiD. Not people who are already there then who went on to get it, but authorities saying these beds will be used for this. And some of it, I think, is due to the misunderstanding and perpetuation of myths around palliative care, which that euphemistic language, medical assistance in dying, has caused confusion. It sounds like, you know, we're helping you die well. Well, that's what palliative care does as part of our role. We help people live well and die well, but we don't end life. And MAiD has been promoted as an end-of-life care option rather than it being ending of life. And so I think when you have limited healthcare resources, you have people who aren't educated in palliative care, and then you have now this new health service put forward, and the government saying you need to provide the public with access to this. Some jurisdictions and regions actually inserted it into palliative and end-of-life care. And so coordination teams and programs were then tasked with managing and providing MAiD, which has actually led to a number of people leaving palliative care, because that's not, in palliative care, we don't do things to end life and hasten death. And so it can cause a lot of demoralization around that holistic person-centered care, if that's your reason for going into palliative care. But it's also taken away from our ability to do our holistic care, where we come along. Sorry, I'll just wait for the background elevator music to stop. When people express a desire to die in palliative care, we understand that that can result from many different types of suffering. It can be demoralization, depression, just a grief or lament, or coming to terms with a new reality as something in your wellness changes, for example, or your role in life changes. And we come alongside someone and we try to understand what's going on for that person and what it is that they're dealing with and how we can help them get back to living. And so our role is to really understand suffering and alleviate it. But when we try to do that now in this new reality in the culture of MAiD, which you talk about in the book, we're actually seen as trying to convince someone out of getting something they have this right to, and we're actually obstructing MAiD when we're actually trying to provide our unique expertise in helping that person. And it's not that that person doesn't have access to MAiD, that can happen in parallel, but we have something unique to offer. And now we're seen as being, against MAiD and obstructing MAiD. And it's this knee-jerk reaction now. If someone says, I'd rather be dead, I can't imagine living like this, it's interpreted by many people now as a request for MAiD. And so the MAiD team is sent, or the paperwork is put in, and it just becomes this kind of process-oriented rather than caring about the person as a whole being, as you said, Rebecca. So it's quite transformed the work we do. I know many people colleagues who have either left the practice of palliative care or retired early because of the situation that we're in.
And I think that's really a sobering portrait to paint for us in light of the the impending expansion to mental illness. And Sephora, something I really appreciated about your chapter was tracing the development of when they were first talking about introducing this, mental illness as the sole underlying condition was specifically excluded. It was not going to include this. And now next year, we're bringing it in. Especially in light of how it's transforming palliative care and the care we're offering in healthcare, what are your concerns about what this expansion will mean for psychiatry and for mental health care?
Thanks, Rebecca. So, I have a lot of concerns about this expansion. I don't think that the healthcare system is ready at this moment in time to be able to include mental illness as a sole underlying criteria for medical assistance in dying. One of the issues right now is that even the term irremediability that is used in the law to allow for eligibility is really hard to apply to mental disorders. And there isn't even any consensus among our professionals about how we might go about doing that. There was a expert paper that was written in 2016 by the Canadian Council of Academies, the CCA. And they really nailed it when they said it's not that we're debating whether mental illnesses are irremediable, but it's whether we can accurately predict that the person in front of you has an illness that will never get better. And this is so much more difficult to predict in the case of mental disorders compared to other illnesses like cancer that has a very clear trajectory. When Bill C-14 came out, second to the Carter case, I think one of the major safeguards that they had in Bill C-14 was that they relegated medical assistance in dying to people whose deaths were reasonably foreseeable. Also, whatever that means too, because that is also debatable. It could be, next month, or it could be 6 months or a year. So even that phrase is up for debate. But in any case, I think the legislators had recognized at that time that we want to allow people who are near the end of life to be able to escape a painful death. But then with the advent of Bill C7, where the reasonably foreseeable death was removed, we've now shifted to moving away from allowing people to escape a painful death to now escaping a painful life, which is a very different thing. And when the Bill C7 first came out, mental illness was explicitly excluded from that bill. And so I testified at the Senate in 2020 at the Senate pre-study, and this wasn't even a question. We thought that, okay, mental illness is not on the books. But then due to a lot of pressure from the Senate chamber saying that, well, if we were to exclude mental illness, that would be discriminatory against people who have mental illness. And so there was a lot of pressure, and it seemed like just overnight the tables turned. And then they gave us a 2-year sunset clause before enacting MAiD for mental illness. And that 2 years was not to debate whether or not we should expand euthanasia and assisted suicide to people who have mental illness, but it was how to put safeguards and protocols in place so that we would do it in 2 years. Then the government gave us a year. So this was supposed to have already been enacted in March 2023. There were 17 medical schools. The chairs of the departments of psychiatry wrote a letter to the government saying that the healthcare system is not ready for this. So, thankfully at that time the government listened and they gave us a 1-year extension, but it seems that the train is still heading towards that start date of March 17th, 2024, when this will be expanded. The concerns I have right now is that the entire healthcare system is set up to help prevent suicides. And so as a psychiatrist, where most of my professional life is spent preventing suicides, it's very difficult to imagine what life is going to be like when we are now being asked to facilitate the suicides of our patients. And secondly, the population that is going to be targeted the most of my patients are very disenfranchised, marginalized. They do not have access to quality medical and mental health care. And it's not even the people who are on the margins that are going to be affected by this, but I mean, even my patients who are fairly well-to-do arrived in Ottawa, which you would think is a fairly well-developed city, and were appalled to see the state of mental health care in the city, the lengths of wait times to access therapy that is not paid for by the government, because most psychological services, you have to be able to pay for it. If you don't have insurance, then you can join the queue and wait for a year or two before you can access services. So even if you're not poor, you're just maybe like, you have a job, but you don't have insurance, and you're just scraping by, paying the bills. If you become ill and you need care, it's going to be very difficult to find. So if that's already the way the state of things are for people who have some money, but they're not totally wealthy, then can you imagine how difficult it would be for people who are homeless or struggling with addictions or unemployed? They might have a physical disability on top of that, which then puts them even higher at risk, as we've heard from our previous speakers, where this system is very ableist, and oftentimes people will push their own agenda and devalue their lives. These are things that have been baked into a system that is fairly unjust. And so it is into this kind of context that we are thinking about expanding the law to include people with mental illness, who we know are the people who are struggling the most, because if one has a recurrent mental disorder, it's very difficult to maintain a job. So, my patients oftentimes are the ones who are struggling the most. And I think that when the law rolls out in March of next year, we're going to have people die who could have otherwise gotten better if this law wasn't there, and if we had the social supports, accessible housing, actual medical care for these people and a community around them to support them and help them to feel loved and welcomed, these people are at high risk now for being incited into choosing a medically assisted death because our society has failed them.
On that note, I want to ask you, Dylan, if you could talk to us a little bit about the scapegoat concept that you mentioned in your chapter, because I think that connects well to what we've been hearing about the impact that this has on populations that already have difficulties accessing medical care, already have these vulnerabilities. So can you tell us a little bit more about the comments that were made about scapegoating in the Rodriguez decision in the 90s and how that's sort of been upended in the Carter decision and the way that MAiD has rolled out?
Thank you. Yes. Okay. Before I dive into the Rodriguez decision of 93 and the dissent in that decision at the Supreme Court, I want to take you back to another case, a different case, because it's an interesting bit of case law history, legal history. So in the year 1932, the British courts developed new law on what we call now the duty of care and negligence, okay? The reason that that's important here is because this was, as I say, new law. It was breaking new ground. It was controversial at the time. And what they did was the court, the British House of Lords, picked up on the dissenting opinion in a previous case. So if you want to predict case law, a good place to look is at the dissenting opinions. So if you look at the dissenting, and that case, by the way, is Donahue versus Stevenson of 1932. If you look at the Rodriguez case at the Supreme Court of Canada in 93, you will find a dissenting opinion by then Justice McLaughlin and Justice Claire Lheureux-Dubé. Justice McLaughlin at the time was not the Chief Justice, but a Justice of the Supreme Court. And in their dissenting piece, here are the facts. Sue Rodriguez wanted to die by assisted suicide. She wanted to be assisted in that death at a point in time when it became impossible for her to do it, quote, by her own hand, because this would allow her to prolong her life, because she had a degenerative disability where she would no longer be mobile enough to do so. So the argument being put forth in Rodriguez in the dissent was we have to let her do it, or else she's going to be ending her life prematurely. So to extend her days, we need to legalize assisted suicide. And in that opinion, Justices McLaughlin and Lheureux-Dubé, the piece was written by McLaughlin and seconded by Lheureux-Dubé. They put forth the following argument. They said, Sue Rodriguez is being asked to bear the burden of the rest of society. The court here, in the majority, they said, wants to uphold the ban on assisted suicide to prevent those from choosing assisted suicide who might choose it in a moment of weakness. And Sue Rodriguez is now being asked to bear that burden. She is a, quote, scapegoat. So if you go back into Judeo-Christian history, you'll remember that a scapegoat was the goat that the Israelites would load up symbolically with their sins and send out into the wilderness to die as a means of atonement, to symbolically load up their sins on this goat and send it out, right? So Sue Rodriguez was, we were told in that dissenting opinion in 93, the scapegoat being loaded up. I'm not sure you can say with the sins of society, it was some kind of perceived sin, okay? And being asked to bear the burden of the rest of us. So you fast forward to 2015, and by the way, when a Supreme Court reverses its decisions, you typically see a longer period of time than between 93 and 015. It normally takes more time than that, but that's another conversation. So the point here is, and I'll try to wrap this up, is effectively, there are two scapegoats. There's Sue Rodriguez, right? And I want to be respectful because obviously there are people suffering in those circumstances, right? But there's Sue Rodriguez being called a scapegoat. But what about the one suffering undue hardship who might choose assisted suicide in a moment of weakness, right? Can it be said that they too are a form of scapegoat if they are allowed to choose euthanasia? So it seems to me that in the Rodriguez decision, between the one scapegoat who's perceived as more autonomous, Sue Rodriguez, and the other who is admittedly seemingly less autonomous, who might choose euthanasia in a moment of weakness, it seems the option that McLaughlin and Rodriguez chose was the more autonomous. They want the more autonomous one to be able to make that choice at the expense of what? Of who? Of the less autonomous choosing that option in a moment of weakness. You see, so that's really the argument here, is just to sort of open our eyes to the notion that autonomy, I think, in today's day and age is being lifted up like a sort of idol and prioritized over the other values in this liberal democracy that we live in. And so the price of upholding or worshiping autonomy, or the sort of hero self, if you will, is that there are people asking to be euthanized. And I think it breaks a lot of people's hearts knowing that. And, you have two medical professionals here who can tell you far more about that than I can.
I jump in. I think the other price is medical professionals like ourselves who don't think necessarily that that's in the best interest of the patient. And we are no longer, in the way that this culture is moving and the expectations that are coming before us from our regulatory bodies, going to be able to give our professional opinion after many years of training and coming to know the individual person, to give our recommendation about what we think would be a good option in the context of all of the unique circumstances of that person. We are being required and suggested that we recommend MAiD to people who may have a treatable illness. We don't even have the opportunity to come alongside and understand their suffering. Yet if they demand, because of their autonomy, I want to be dead, I want MAiD, then we are being required to facilitate that. So it actually is completely changed also the standard of care within medicine. And that's a whole nother conversation as well. But yeah.
Yeah, along the lines of the standard of care in medicine, Canada is now the most permissive country once it extends it to mental illness in 2024. In most other jurisdictions where euthanasia for mental illness is permitted, both the medical practitioner and the patient need to come to an agreement that there are no other viable and reasonable alternatives. Whereas in Canada, the patient is allowed to decline treatments that they feel is unacceptable to them. And then it's really, the opinion of the assessor whether they would be eligible for euthanasia or not. And we know from media reports that the spectrum of euthanasia providers and assessors vary widely. And some providers have stated publicly that if a patient is on a wait list and the therapy that they are needing is not available for a very long time, and that they would, be suffering during that time, well, that's still suffering. And so they would be inclined to provide MAiD to these patients, even when there's a therapy that's available, but just inaccessible because of wait times, which I've already mentioned is one of my concerns in terms of the inability to access care in a timely fashion.
And I'm conscious of wanting to ensure that we reserve time for questions from the floor. But before we do that, I'd like us, what can we do? Because we have here people who are in the politics world, the policy world, in the medical field, in the legal field, but also all of us, even if we don't have a profession that touches directly on these things in a sort of practice sense, all of us have our own bodies, we have family, we have friends, we are either currently or will or have experienced illness, and at some point in life, the end of our lives. So how do we engage in this issue in a constructive way that addresses some of these challenges that are, some of the issues surrounding the impact it's having on practitioners, some of the populations that are maybe receiving suicide promotion rather than prevention, all these kinds of things. What are some things that maybe we can take away as people throughout this realm of professional experience, but also with the personal experience?
I can start with that. One idea that I've been really trying to advocate for is ensuring that there are safe spaces within society for patients to receive care where they know that the healthcare professionals providing care in those facilities will not put MAiD on the table unsolicited, and that it's a safe place for them to be able to go to. I think that would also help to maintain healthcare professionals who don't want to be involved in MAiD, because as Dr. Herx was saying, many physicians are leaving the practices of palliative care. And I can say from my own profession, psychiatrists who are retiring early because they don't want to have to deal with facilitating suicides for their suicidal patients. I think having sanctuaries where both patients and healthcare professionals can go to receive and provide care would be essential and sort of very common sense to me in a society that has decided to allow euthanasia and assisted suicide as part of the medical treatment. And then the other thing that I wanted to highlight in terms of any politicians in the audience, in 2017, the Canadian Psychiatric Association had come up with suicide reporting guidelines. And this was in an effort to reduce suicide contagion. And part of those guidelines is that you're not supposed to glamorize suicide. You're not supposed to publicize how suicide was committed. And you're not supposed to portray suicide as a reasonable solution to life suffering. And what have we seen with the media stories on medical assistance in dying? It's all of those things, right? Yes, there was.
Oh, just yesterday or the day before, there was another CBC glamorized story about this couple in, was it Winnipeg? Saskatchewan, I'm sorry, who chose to have MAiD together. But it was like, if you actually look, it's like a murder, like it's like a suicide pact, right? Because one person had a life-limiting illness, the other one didn't, and the wife asked to be killed at the same time. But this is the third, I think, story of CBC glamorizing a couple who died together and just how romantic and wonderful it is.
And so we are already seeing patients who have been seeing these news stories and thinking, oh, MAiD would be good for me. So I think that in terms of a public policy perspective, reporting guidelines for MAiD should follow the same guidelines as for suicide reporting.
If I might add, is that all right? And then we'll pass it, keep going down the line. Okay, good. So I totally agree about the safe spaces, and people should have a right to choose to go to a place where they know MAiD isn't going to be provided, or a doctor's not going to suggest that they would be better off dead. I think it's really important that MAiD is a patient-initiated discussion, so we shouldn't be bringing it up, which is what's now proposed in the new Health Canada model standard for MAiD. I think that we need to do something at a legislative level, which we did try to do during Bill C7, but that's it. We still have another opportunity to do that, where it must be a discussion initiated by the patient, not by another person. Because I know many patients who have only asked for MAiD because their trusted doctor suggested it to them, and they get then afraid that their symptoms are going to be so terrible, they're going to have a difficult death, that they better end it now while they can. So I think that would be really important.
So Dylan, do you have a last word for us?
I do, and I'll address it to those working in the political offices a stone's throw from here. Whoever you are, anonymous sitting in the audience, you're certainly welcome. So here's what I would suggest in two parts. Capital punishment was abolished, I think in 67 or so. Someone can correct me on that. And one of the main reasons for that was that one wrongful death is too many. We're now looking at a state sponsored, state facilitated administrative apparatus in conjunction with curriculum development within the medical schools, within the colleges, affiliated with medical, pharmaceutical, call it system. It's all integrated, right? And it's all being rolled out. I would submit to you that if government could investigate the records, the coroner's records, and if one wrongful death could be found, one case of someone who chose euthanasia or assisted suicide under the duress of their circumstances, then the law needs to be repealed. It's as simple as that. You're dealing with Section 7 of the Charter, so you're dealing with Section 33, which is the notwithstanding clause. You'd have to trigger the notwithstanding clause. There's a sunset on it. And maybe you say to yourself, you bar it or you repeal it. And if it's, for whatever reason, forced upon you again to allow euthanasia and assisted suicide, there's a mandatory re-examination of all the coroner's records, a full investigation across the country, and again, you start the cycle back. One wrongful death is too many, and you repeal the law. I mean, it sounds extreme, but we don't have capital punishment. Do we say that's extreme? Sometimes it feels as though it's the lobster, the proverbial lobster boiling, right? And it sort of takes some among us to say, no, we're boiling. You're not crazy. It's boiling in here. So that's my.
Add one more thing. Sorry,
10
I'll keep it really
seconds in.
short. Okay, this is practical advice because you also said, what can we all do as individuals? So one, you're getting educated, like broadly, like hear all perspectives, understand the issues. But the second thing, and I learned this from my dear friend and colleague, Nicole Scheidel, who's back there, and I had now say this to all of my patients and families, don't go to the hospital alone. And I say that very seriously, because people go to the hospital in a state of vulnerability, something significant is happening, and can be pressure and coercion, and I know this directly from patients directly, that they have been offered MAiD in an acute emergency room situation in a very compromised state, and they feel pressured, and if they're alone, they're more vulnerable to agreeing to something they might not have otherwise. And so I say that very practically, and I think it's actually very important.
All right, so we are going to have a number of questions from the floor. My colleague Monica is going to help facilitate that. I know we have some questions coming in from online as well. So one gentle reminder that I will maybe present is that because there is a lot of interesting questions, is that we keep our questions to questions and maybe reduce the desire for preamble and commentary that I know that is within all of us, so that we can have as many questions as possible.
Amanda Ackman, and my question is for Leonie. Often when I tweet in opposition to euthanasia, people say, you clearly have not witnessed an agonizing, grotesque death, basically a death that is totally repulsive and undignified. So I want to ask you, given all of your palliative care experience, how would you reassure such people that no one's death is actually so repulsive that you would rather kill them?
Well, I mean, I think I would just say that we live in the 21st century and we have amazing care for people who are approaching the natural end of their lives and great medications, and that there is no reason for anyone to be dying in pain. But I would also talk about total suffering, and that sometimes it's actually our own suffering at the situation of another person that we're putting onto them. And so I think that's another thing that we need to start reflecting on, is who's suffering and what is it about. Thanks.
The panel. I have a two-in-one question. So in terms of narrative and how we frame issues and euphemisms, I think we all know that before we change the way a society thinks about a particular issue, the language changes. So when medical assistance in dying first came out, I think we can all agree that's really not a very precise definition. And, you know, we've all talked about the CBC and other media stories. So one question to all of you is, how do we change the narrative and use more specific language? And I did notice that Dr. Tang used the term euthanasia. So that's one question. The second question is, as a physician, I know Dr. Herx and I have spoken, and she has said, and I agree with her, that, you know, in terms of the medical profession, what you really need to be an effective physician and to have a healthy society is to have trust between individual doctor and individual patient, but also society and the medical profession. When you then introduce doctors, and nurse practitioners also are MAiD providers, but when you introduce doctors as those who are charged with putting our patients to death, do you feel, sorry, this is kind of rhetorical, but I can't really help it. You know, it's a way of sanitizing what's happening. The doctor is going to put you to death. It's called a procedure. It's called a process. I can't remember the exact, yeah, there's actually a term that's escaping me right now. But again, it is changing the language and making it more palatable to everyone. How do you propose that we get around that so that doctors can get back to doing what they're supposed to do and regain the trust of society?
Okay, well, so number one, in terms of the use of language, I think it really is important to call things for what they are. And so that is the reason why I will sprinkle into my talks euthanasia and assisted suicide, because that's what they are. Medical assistance in dying isn't even it's not even medical assistance in dying anymore, because patients are not necessarily dying. It's more like medically assisted death. So I totally agree with you that the more precise use of terms would be helpful in helping people to actually understand what is happening. And I also totally agree with you that having physicians and healthcare practitioners be the ones to administer the lethal dose is a way of sanitizing or legitimizing the process. Patients will say, well, I'm going to get medical assistance in dying. This isn't suicide because a doctor is doing it. And so even in the minds of the patients who are availing themselves of this intervention, they're not really realizing the truth behind what is happening, because it's being covered up by the language and it's being covered up by the people that are being called upon to enact it.
No, I was going to maybe a bit pithy and say, you know, that this idea of the medical assistance in dying, if I were to draw a bit of an analogy with the legal profession, it would be a little bit like encouraging lawyers to help their clients break the law, but calling it legal assistance in getting around the law. Right?
Hi, first, this is a superb book, and I'm entirely in sympathy with the views of the panelists. But I want to raise another question for the physicians, which is whether there should be some regulation or work on changing how the offer of MAiD is made and communicated. And you may think that, no, we don't want it at all, but if it's going to be here, I think it's something we need to think about. May I briefly illustrate this with my case? I happen to be a cancer patient with a terminal prognosis, and when I relapsed, I had a meeting with the surgeon who'd done my biopsy, and in 5 minutes, I was given the results of the biopsy, his opinion that there was nothing else that could be done, a prognosis of less than a year to live, and an offer of MAiD. And I mean, actually a professor of psychiatry and epidemiology here at U of Ottawa, and I do a lot of suicide prevention work, and I'm quite well aware of the impact of communications like that on people's emotional state and the risk of impulsive suicide immediately following communications like that. So, I mean, I guess I would ask you, how do you think, if MAiD is going to be an ongoing reality, we should be training physicians who want to make this, well, I should also mention that this is an entirely unsolicited offer of MAiD, but how should we do this? I mean, at least there should be some sort of waiting period to allow people to assimilate the information about their prognosis, et cetera. Anyway, thank you.
I guess I'll go since we're going this way. Where did the other mic go? Oh, okay. Oh, yeah. Right. I thought there were three. I think I mentioned it earlier. I feel very strongly that MAiD should be a patient-initiated discussion. And if someone is expressing a desire to die, certainly I will always clarify with the person what, that in Canada, medical assistance in dying, and I explained that it's euthanasia and assisted suicide and what it is a legal option. But I don't think that doctors should just be raising it at any point unless the patient asks. I think it should always be solicited by the patient. Yeah. I think there's too many, and that's a research area that we need to look at, is what sort of subtle pressure or overt pressure is put on patients when a doctor who has a trusting, and there is a relationship, a power differential, because if someone with expertise and training is there to give you their opinion, there is something, I think, there in that that might push a person who feels vulnerable or is in a moment of despair or that they might consider something they wouldn't have otherwise.
I completely agree with Dr. Herx that the raising of MAiD needs to be patient solicited or initiated. And, Dr. Herx had mentioned earlier about the Health Canada model practice standards that are being rolled out to apply to MAiD in all circumstances. They haven't actually done a specific document for MAiD for mental illness. And it's recommended that the healthcare professional, if they believe that the patient meets eligibility criteria for medical assistance in dying, should be mandated to put that on the table, which, and if they think that it's in line with the patient's values, but I mean, how are you supposed to solicit whether euthanasia and assisted suicide is in line with the patient's values unless you've, kind of asked them? But, I think the impact on a patient receiving this as a potential treatment intervention is kind of devastating. And I'm really sorry to hear that you had that experience, because I mean, what does that say to an individual hearing that message, that we really don't think that we have any hope for you, and this is one of the options that you should consider? And as a psychiatrist, we are there to kind of be the bridge between someone's despair and taking them to a place where they can hope for something. And what they hope for might change, as Dr. Herx knows very well in palliative care. We're trying to optimize the quality of life of an individual, and the things that you're hoping for might change as your illness progresses, but there's always some reason to hope. Even if at the end of the day, you might be dying, but there is that window where there's potential and there's fullness in life that can still be lived, be meaningful. I've had the honor, not as much as you in palliative care, but I had an interest in psychosocial oncology before I went into general psychiatry, which was ironically to escape the whole prospect of the Carter decision, but here I am now. But anyways, journeying with people who are at the end of life, or where that the time is short, is such a meaningful time where there can be reconciliation that happens. A person comes to a sense of peace at their end of life, and you're able to journey with them to their natural end. Those are some of the most powerful and moving experiences, both for the person journeying with them and for the person who is dying and facing their own mortality. So I think with the advent of legalized euthanasia and assisted suicide, it really is robbing individuals of a very precious time in their life where death is sanitized and constructed and timed and controlled. But that's not really how life works. And when we deprive an individual of these opportunities, I think that's a loss for everybody.
Sephora made me think of a quote from a palliative physician, A.J. Donkin, who writes, and I cite him in the chapter here, but I think it's useful. He says, an expression of a wish to die may be more a question than a statement. Am I of any worth? Am I in the way? Patients are looking for a picture of themselves in the eyes of their beholder. If the answer is returned that they should be helped to die, it is an affirmation of what they suspected, that others now see them as worthless.
So I think we have time for 3 more questions. I'm getting the signal from my colleague, but we're going to make sure that they are relatively brief questions so that we can fit them all in.
Yes, and they're the 3 people I've made eye contact with you. So that's why I feel committed to the 3 more questions.
Yeah, I just wanted to say, as a person that was suddenly catapulted into the eligible category by C7, that the whole idea of choice is overestimated. The idea of MAiD has 2 aspects. One is choice, but the other is objective justification, that there are certain circumstances in which it's appropriate to kill somebody. Now, those 2 ideas are fundamentally opposed. There is no patient demand for MAiD. And statistically speaking, of course there is, but statistically speaking, there is not. Normal people do not want to die. Most patients don't want to die. The greatest incidence is in the Netherlands, where amongst terminal cancer patients, 10% consent to be euthanized. That means that 90% do not, okay? So what you're looking at here is 2 completely different philosophies of medicine. The idea of saying that one doctor can do both is, in my opinion, silly. These different forms of medicine proceed from different philosophical basis, and they're practiced by different people. And as Leonie says, what we want is to have sanctuaries, and Sephora says we want to have sanctuaries. What we must do as a society is we must demand those sanctuaries. And it's very possible that our government won't give them to us, because it's perfectly possible that the utilitarian herd management trope is where we're going officially. It's possible that it will be impossible to have real medical service within the government system. So we have to be prepared to reinvent the wheel. We have to go back to the fundamental Hippocratic distinction. And people, first of all, we have to inform people of this existential fight that is going on. And then the people have got to take it to the streets and say, we must have real medical care. We must have real doctors.
Thank you so much for that. I don't know if there's an adequate response. So thank you, and we'll invite the next question, Monica.
Thank you. This has been very, very good. I so appreciate the euphemisation of MAiD and just how that actually comes into play. And my question is actually pretty simple, is based on the statistics that we know, an overwhelming majority choose euthanasia over assisted suicide. Like assisted suicide is almost inconsequential. And I'm wondering if anyone has thought about or reflected on why that is and what's its significance to this.
We all have thought lots about it.
Well, actually in Quebec, assisted suicide isn't even legal. Only euthanasia is. And obviously there's the risk that an assisted suicide is not going to succeed. And so there's the risk of more harm, which is the reason why, most people the reason why many people don't commit suicide is because they're afraid they're going to botch their attempt and then end up in an even worse state. So with euthanasia, it's like fail-proof. You have a physician that's right there ensuring that you are going to be dead. So it's,
I guess I worry, and we don't have the answers, but I think we should probably do some of these studies to look at, is it easier to have something done to you by a doctor than it is to do it yourself? Because that has a whole different feeling. And I raised that because I had a patient in hospice once tell me that they would never do it themselves, but they were happy for the doctor to do it for them. And I think there's more to unpack there about why that feels different to a person, because it's like this procedure and it comes back. I worry that there is some influence about the sanitation. And I've actually had patients tell me that they felt they were letting the doctor down if they changed their minds. I've also had patients tell me that. So I think there's a lot more that we don't understand than we do understand.
Hi, I'm Joel Agarwal. First off, thank you very much for this conversation. Dr. Leonie, you mentioned something that broke my heart. I wish I'd never hear it from a healthcare professional. Just don't go to a hospital alone. And I think this point was brought up earlier, the topic of doctor-patient trust. And where I'm from, back in Alberta, there was a Kai-High report that showed, I think, somewhat 40% of people don't have continuity of care, patients. And my question is surrounding that sort of a doctor-patient relationship, where the patient feels known and understood. There's a continual relationship. There's a lot of literature that shows that increases health, better health outcomes. And I'm curious, from the healthcare perspective, if there's a way to improve that trust, if there's a way to integrate primary care physicians to have better trust with the patient, so that patients feel that they can talk to someone who they trust and they're not going to end up in the situation where all three of you have described.
Yeah, I mean, I think family medicine primary care is quite broken in our country, to be honest, right? So I think what you're describing in Alberta is similar across the country. But I think that you can have very meaningful relationships with people, even if you haven't known them for a long time, if the physician gets to know the person, right? And understands who they are as a person. And so our colleague, Harvey Chachanoff, has done a lot of work around how do you tell patients that they matter, right? And it's that human aspect that is so vital to having a trusting relationship. And you can achieve trust in a shorter period of time if you provide that type of whole person, intensive, caring, dignity affirming care that tells the person they matter, right? And so that actually people can be trained on. So I would say all healthcare professionals should have that type of training to help us be better carers of people and stewards of healthcare, so that we can help affirm people's inherent worth and let them know that they're valued for who they are. So
I think I'll also add the necessity to protect the freedom of conscience of healthcare professionals. What we're seeing now is that even if a healthcare professional is opposed to certain interventions, that they must make an effective referral. And so it seems that it would be difficult to trust where a healthcare practitioner is coming from if they're not able to abide by their conscience. And so can you really trust that the individual who's providing you care is really doing something that is in your best interest, or are they just following college guidelines that seem to indicate that euthanasia and assisted suicide are, interventions that should be put on the table for patients, right? Like, I think just by not protecting freedom of conscience and allowing clinicians to maintain their clinical and professional judgment about certain medical procedures, this really puts into question the trustworthiness of the medical system that we are trying to build currently. So freedom of conscience is something that I strongly advocate for, and I think this is the backbone of a healthy medical system that patients are able to put their trust in. And without this, when you have the state interfering, this is the beginning of eroding that trust.
So thank you so much for our panelists for their responses and to all of you for your questions. We're going to wrap up the Q&A period at this time so that you still have some more time to continue the reception, to continue having conversations with the book authors and editors, as well as maybe the other Cardus staff. We'd love to hear your thoughts and ideas on the health program about how we can be addressing these issues. We also invite you to look at our recently released report on euthanasia and assisted suicide and the ethical issues there within. And if you're not already paying attention or subscribed to our health newsletters and emails, we have more research coming out later this fall that if you're subscribed, you will get quickly and efficiently into your inbox. So I'd also like to just offer a final thanks to the editors, to Jaro and David for their work on this book, to Irmo and our other panelists for speaking, to the other book authors who are with us this evening, and for all those who joined us online. Thank you so much for your participation. We invite you to continue the reception, to continue the conversation, and you can help continue that conversation by checking out the book. We'll provide that information on the placard in the lobby as well as in the email you'll receive in your inboxes tomorrow. Thanks and have a good night.